We're very fortunate to have Andy Shih today talking to us. Andy Shih will talk about global autism community, collaboration, implementation, and progress towards equity and inclusion. Andy Shih is a scientist. He is also the Chief Science Officer for Autism Speaks, which is one of the most well-known non-governmental organization based in US, but with a global scope of work. And he has been in Autism Speaks for, I was told, 22 years. And he did his PhD in cell biology actually before that. So he was a proper basic scientist, but the kind of work that he'll present is actually using that science to make a difference, which is very important for people in public health. So without any further delay, I would like Andy, you to present it. Take about 30-35 minutes, and then we will open up for discussions. So Andy, over to you.
Thank you very much, Shekhar. Just want to thank Shekhar and others again for giving me this opportunity today to share a little bit about the work that we do globally with the community here. So this, I always love this first picture I have on the screen. This should come from a conference that we held in Sao Paulo. These are autistic young people doing a dance of joy at the end of the conference, and this always represented to me the vitality, the energy that's really in our community to push forward and make change happen in a more accelerated fashion. So I know everybody probably have a pretty good understanding of autism, but let me just go over some of the basics so we're on the same page as we talk about autism around the world. Obviously, it's a broad range of conditions characterized by social communication challenges, as well as some repetitive behavior and other issues. You can typically be diagnosed behaviorally by age 2 or 3, and in early intervention, we know it demonstrated can enhance functioning as well as inclusion of these children and individuals in family and community life. And because it's a spectrum disorder, it's really experienced differently by different individuals, and each of them is remembered. It's important for us to remember that each of them come with their own strengths and challenges. Some may need significant support in daily life, 24/7 often, while others may need less support and can live very independently. Autistic people often experience sensory sensitivity, other co-occurring health issues such as GI disorder, seizures, sleep disorders, and so on, and as well as older years, especially in the older years, anxiety, depression, and other mental health challenges. Autistic adults are 2.5 times more likely to experience premature death. In the U.S., it was published last month, actually earlier this month by the CDC. The prevalence in the U.S. is 2.7%, and for the first time since the CDC started keeping records, the prevalence among minority children age 8 in this country is higher than non-Hispanic white children in the United States. This trend has been occurring for a number of years now, but it's finally documented in the latest report. And about 25% of the total population have intellectual disability and considered medically fragile. And autistic people, need to say, in their family experience stigma, discrimination, and inequity, and well-being, as well as health outcomes across the lifespan. So this is really what we're talking about here. So the area in orange are the high-income countries, right, according to the World Bank. Just is really to remind myself, as well as listeners, that vast majority of our autistic people and their family lives actually outside of high-income countries. And their daily reality actually is a global treatment gap of more than 90%, according to WHO. So what that means is that the kind of service support that many autistic children and their family are accustomed in a country like the US and Western Europe are largely an aspiration for most of the families affected by autism in the world. And so what we clearly need is an ability to address this global capacity shortage of services and we need to find a way, sustainable way to deliver timely effective autism services, especially in rural settings. But this is the challenge we set out to try to address, really working collaboratively with many organizations. And just to further focus the conversation, we're really talking about here, trying to develop a solution that's in the community setting, focusing on self-care as well as home and community care, where the needs are probably the greatest, and also the gap is also the greatest. So just a brief history in terms of our role in development of our autism-related efforts. We started in late 2000, 2007, we had the Autism Network. The outcome of our investment early identification, early detection of children with autism. The question became, if we can identify children as early as 18 months of age, what do we do? How do we support them? So we formed this research network that we start talking about exploring a solution that can be helpful to these individuals and families. Of course, thanks to the same time, thanks to the state of Qatar, the Autism Awareness Age Resolution was introduced and passed by the UN in 2008. Autism Speaks launched what we call the Global Autism Public Health Initiative shortly thereafter, with 2 countries involved. Initially it's Ireland and Albania, but it certainly has further developed. In the context of this Global Health Initiative, we issued RFA in 2011, really trying to, sorry, I should have jumped here. You're really asking the question, how do you make evidence-based intervention accessible in low-resource settings? Simultaneously, or parallel, the Republic of Bangladesh tabled the second resolution at United Nations, really addressing social and economic needs of individual families and society affected by autism. This was quickly followed by a consultation, first time I think in WHO's 64 years of history at that time. It was the WHO consultation on autism, which I was honored and privileged to work with Shakara on at that time in WHO. And then what was recommended from that consultation was that parent training was a solution, potential solution to address the capacity shortage and great unmet needs, global needs at this point. And quickly thereafter, there was 2 things that happened in 2014. First was that World Health Organization, World Health Assembly passed a resolution that we point to the comprehensive coordinated management of autism spectrum disorders. And at the same time, we were able to bring advocates and stakeholders in over 30 countries to Geneva to meet with WHO staff and to start talking about the development of this new program to support children and families in low-resource settings.
And just a small interruption. Jessica, can you check whether people on Zoom can hear him well, or you're sure? Because he's not using a microphone.
I can't actually hear very well, and I was going to put something in the chat, and I have my volume up all the way.
Is there a portable microphone?
Is there a microphone that one can use?
No, we don't have a portable microphone.
Must be
I try to speak louder.
Well,
you shouldn't have to. There should be
If you can just try to speak
there should be a
louder.
microphone on the podium.
I just have
No, we don't have
a pointer.
No
It's built
microphone.
into the room, that's why the microphone.
I'll try to speak louder and slower. How about that?
Sorry about that.
No problem. My apologies. So in 2014, we had this meeting at WHO as we launched the caregiver skill training program initiative, and it was really a consultation of the community. Autism Speaks were able to bring in some of the key stakeholders from over 30 countries to Geneva, where Shakar and his team had an opportunity to present them the concept of this package and some of the features that will be that are planned to be in this package. We're really asking for feedback from community stakeholders. And this group of stakeholders including parents, service providers, some policymakers, and researchers as well. And following on that, we started the process of developing the caregiver skill training program Fortunately, in 2015, our original investment made in 2011, the RFA 2011, resulted in the first publication by Atif Rahman et al. And working with Jonathan Green and Vikram Patel, where they really demonstrated first time by using task sharing strategy, they were able to train non-specialists, including caregivers, in essentially intervention naive community. This is rural in Goa, India, as well as Rawalpindi, Pakistan. They were able to demonstrate that not only were they able to successfully train non-specialists in this highly technical intervention, they were able to deliver successfully, actually achieve the same level of impact on both caregiver and child at same time in the country. So that was really for me a tipping point in terms of what we think are possible in terms of supporting our community in the larger world. And so quickly thereafter, we're able to convince, persuade 18 countries to really get involved and start to field test this program. The WHO delivered a field testing package, and I'll go into a little bit more. And my job was really trying to sell this to country governments. And then so there were obviously sustainable development goals introduced in 2016, and while the research was already ongoing, and quickly followed by additional investment by various countries in really trying to generate more evidence to support the use of this program. So the caregiver soul training program was really developed for caregiver children 2 to 9 years of age who had development delays with disability, and the specific focus on caregiver with delays of impairment in social communication domain. What I want to highlight is that a diagnosis is not needed for accessing this program, because we fully recognize how difficult it may be for many communities actually to receive that kind of diagnostic services. So parent concern is really the indicator for accessing this program. And the aim is to increase their caregivers' skills to promote their children's development and well-being through joint engagement, play. These are well-known strategies and in home routines. So this is an example of the kind of content that's in this program. Typically involve 9 group sessions in the community and 3 home visits. The home visit allow you to customize intervention strategies based on each family's goals and priorities. But the group session is you take advantage of the scale, and also it helps form these community groups, informal groups within the community among caregivers to support each other going forward. The topics that we cover, everything from engaging the children in everyday activities and games to caregiver well-being and problem solving, because we fully recognize that the caregivers are not doing well, they cannot do their best for their loved ones. Some of the areas that we cover include involving the children to do more in daily activities, following their children's lead, taking turns, responding and expanding child's communication, responding to child's attempt effort with praise and attention. Really, general ACD strategy, but probably focus and different kind of emphasis that are probably better suited for children with developmental differences. And here are some of the outcomes that have been generated from various field trials, as well as some RCT. As you can see, in general, there were both caregiver and child outcomes for the implementation in diverse setting from rural Ethiopia to urban setting in Mumbai, India. And also this was actually a pilot RCT done in the National Health System, and it was a great study. I really enjoyed it. And what we found is that not only is it highly acceptable and feasible in the National Health System, and that we're able to see favorable effects 3 months post-intervention, right? That include dialect fluency between caregiver and child interaction, child nonverbal communication, caregiver skills supporting interaction, and self-efficacy and reduction in stress. All important things for our caregivers and our families. Now, what I found really fascinating, interesting about this whole CST initiative was that it really, from a more traditional scientific perspective, if you look at your left-hand side, which is the MRC UK implementation framework, typically we start with the development stage, right? When you start in development implementation, you start development stage and then you go through that cycle down to implementation. What I love about the CST, that was pointed out to me by Helen McConaughey, is that we start with implementation. We assume that the package is going to be useful. We imagine what we want that program to sit, where we want that program to be ultimately in the community, and we work backwards, right? So we bring the stakeholders together, we come up with a vision on what this program is going to be for that particular community, who's going to be running it, who's going to be using it, how we're going to make it more accessible, and then we try to figure out how to get to that point based on the resources we have in the community. So that implementation driven, and we do this very opportunistically. It's not that we're going to country governments systematically and say, hey, can I help you with putting a development disability program together? We see what is going on. We see what are the national priority. For example, if there's a major push for ECD, we advocate inclusion of our children in those ECD programs. And then we offer them an adaptable package with active ingredient, but it can be customized to fit into their context, right? So that lowers the barrier of entry for this package in many settings. And then as an organization, what we do is that we focus on, of course, partnering with WHO and UNICEF to give us the reach and the impact that we want. We foster and support, leverage local leadership, if you will. And I'll go into that a little bit more. But we typically reach out to the decision maker, the policy maker, while we're working with the community advocacy group as well. So it's really a top-down, bottom-up approach. We also leverage peer-to-peer interaction as well. For example, policymaker in one country with policymaker in another country to further disseminate to help implement this work. We leverage local human and financial resources, broaden ownership, and enhance sustainability. Because one thing we did learn is that even in the poorest country, there's some people with resources you can potentially reach out to and try to really establish a foundation of sustainability for that program in that location. We do provide some targeted investment in early stage of research to generate evidence as well as additional leveraging opportunity. Basically maximize the dissemination and communication opportunity by approaching as many channels as possible within the community. Because many of them will not work out. So our role really is to provide community engagement and to a large extent marketing. So I pitch to the policymaker why they should be considering this package, and some content expertise. We help the training. We have staff that have learned the program and support the training. And of course, we facilitate research collaboration. We do provide some financial support for staff time with our partners. We do facilitate local ownership, meaning we work hard to identify in-country human resources to engage, as well as in-country funding. And again, we see it in leverage research funding as well. So the key relationship for us at the UN are some of the key relationships. For example, the mission member state, Qatar and Bangladesh, has always been very active on this issue. They've really been our champion in the UN community. Of course, collaborating with WHO and UNICEF has really been, they really have boosted our work immeasurably. Government ministry, there's several governments that have prioritized development disability, including autism, as part of the agenda. And we have really leveraged and we rely on this government not only help us move the agenda forward in their country, but also to influence neighboring countries as well. Of course, Brazil, Egypt, Malaysia, China, Canada are all really wonderful supporting partners. An important relationship for us is really the community implementation part of NGOs. And I listed some examples here. Both in the international community as well as locally in the US, in the United States. And of course, we're very grateful for our funders at all levels, global level, national level, as well as so this is our, for me, I think this is biggest reason for the reason that we're able to move so quickly and so successfully. We work with a group called the Advocacy Leadership Network. This was formed in 2010 as a collaborative platform of international advocates. With emphasis on advocacy, dissemination, and communication. Every member of this network, a respected local leader, all have done something incredible for their own community, often nothing, no resources. So their spirit of innovation, their spirit of chance taking is exactly what we need, right, in order to push for progress. There are self-advocates, caregivers, professionals, policymakers, and pretty much everyone who cares about the children and families. We interact continuously on social media. Many of them are my Facebook friends, so I know a lot about their personal life, I know a lot about my personal life, and we meet every other year to exchange knowledge and transfer and collaboration. Some of the high-impact collaboration that we have undertaken, for example, we lobbied in a serious way for the World Health Assembly resolution, having members actually helping the sponsor side event in Geneva to encourage member states to support the resolution, as well as you will see the CST implementation. Some eye candy here. This is when we first launched in 2010. Only 10 countries were present. By the time we got to 2016, the complexion of the network has changed. We also have a lot more people involved at that time. We started to combine some of the technical work with CST with the advocacy meeting in China by 2018. This picture always cracks me up, but it's a great meeting. We also have regional meetings. So this is the one that took place in Addis Ababa, 2020, right before the pandemic. And you can see we were able to combine not only the advocacy work, but also technical work involving WHO and UNICEF as well with these advocates. So this group actually just met in New York last week. We have participants in 33 countries, and they're represented here. You can see pretty well coverage, pretty good coverage. Group picture. So CST at this point has been implemented in over 40 countries, and with about a handful of RCTs. Some are in progress, for example, in Kenya and Ethiopia. And many countries have multiple sites and are starting to do scaling up activities. Brazil, Uganda, Peru are all good examples. China are good examples of that. Many of them are in collaboration with Ministry of Health, Ministry of Public Health, and or local advocates. And the 3 UNICEF sites that we've been piloting for the past 3 years have now entered the scaling up stage. So, and we continue to draw additional participants. For example, this week, we heard from Tajikistan and Eswatini. So, in the US, as you know, we have many similar challenges in low-resource community in the US as we find internationally. So we have also been exploring opportunities to implement this program in low-resource communities here in the United States. So far, we have implemented the program in Michigan, Detroit, largely downtown, the African American population, largely. DC, Maryland, Virginia area, where there's a large Ethiopian Eritrean expat community. So we have actually taken the work that we did in Ethiopia, put it back in the States to serve the immigrant community here in the United States. Pennsylvania and South Carolina are both more rural community in general. And the newest addition in Texas and Rio Grande Valley through University of Texas, where the local population is 98% Spanish speaking, my understanding. As well as New York City, started to work with a culture specific group like the Korean and American groups as well to make this program available. Here's one of the findings that we have working with Easter Seal in rural Missouri. This is really trying to understand how we can use this tool to serve rural populations. So we did this with some telehealth components, and it was very successful. And now we have an opportunity to really expand this to other ECCO sites in the United States. This is actually a really happy story for us. This is working with Charles Brown Community Health Center in New York City. They serve largely underserved families in New York City with focus on Asian Americans, mostly immigrants. So actually, they have done so well with this program. They're on the third round expansion in New York City. They are actually training other service providers in New York City as well. So they're helping us to disseminate the program at this point. During the pandemic, they were able to innovate and do the program both remotely as well as in person successfully, and this caught the attention of Representative Grace Meng of New York, who introduced the American Family Caregiver Act in Congress last year, and yesterday she just reintroduced it with Senator Collins from the Senate supporting this very similar bill. So it's really a lovely story in terms of how we started globally, but we're able to bring it back into the United States, support the community here. Now there's actually an opportunity to find legislative support for this program so that it can be sustained in our healthcare system. The whole package was published by WHO April 2022 last year. Of course, we're very happy about that, and translation underway. I know that some of the, for example, the Chinese version and Spanish version will be available shortly, probably this month, probably in May, coming month. We also have developed an e-learning version of the program. This is in the process. Currently, we're field testing and finalizing the content. But here it is. You can see the English version now is on OpenWHO, and it's basically self-directed learning for caregivers. It's the same as the program. It takes about 8 hours, self-paced, and it's suitable for mobile devices. We have no illusion that this is going to be a solution panacea for all ills in the community, but we do believe that there's a percentage of the caregivers globally can benefit from this in this format. Right? Again, it's about really making this content accessible to as many channels as possible. We have produced additional assets, including animations, that help explain the key strategies involved with this program. Translation of the program is all underway at this point. You see the languages there. And of course, as part of the telehealth movement, spurred on by the pandemic, we're also building the ETOT module for this. We're actually starting to build now. So its idea is using digital training for master trainers, and it seems to work well, and really combine self-directed e-learning virtual classroom time. It will be hosted on WHO. We hope that it will be available by the end of this year, which will further facilitate dissemination and implementation. And this is basically what it looks like, an online training, combination of webinars and in-person booster sections, and so on. And last but not least, a CST 023 is about to be published, be ready for field trial. It's very similar to the CST for 229, but it's for earlier in life, and it's actually will link it nicely to other ECD programs in general at this point. Again, this will be available for field testing, hopefully by the end of this quarter. Additional option modules are being prepared, made available. For example, caregiver well-being, as well as children with minimal verbal skills. And again, there will be, it's not January 23, hopefully July 23 at this point. Last but not least, we have a Tier 3 program in development, and for training for children with social communication impairment. This is more specialist focus, and but it will be based on building competence for delivery of key component of evidence-based intervention, and including CST, and as well as competency coaching non-specialist providers working with families. So this is my last slide, and this really summarizes what we do as an organization in supporting these large-scale initiative, implementation initiative. Is that by working strategically with institutional partners such as WHO, UNICEF, and others, we convene the community, all key stakeholders, to collaborate and co-produce. We then go and help pilot, test, and scale up these innovation, so that we can enhance sustainability and advocacy. And we start advocating for, based on this outcome, advocate for these programs throughout our networks, sharing the source story with policymakers and so on, and also use our social media, for example, to my social media follow on Facebook, to further disseminate and provide global funding. So again, our work is really equity driven. It's implementation focused. It's based on broad and deep continuous community engagement, strategic, collaborative, leverage. This is some pictures from various countries. Thank you very much.
Thank you, Andy, for giving us a very broad view of the kind of things that are needed and the kind of things that you, along with your partners, have been able to lead. That's very good. We have the 13 people who are joining us virtually, and I can see many people who have been interested in this area for some time. So I have some questions to you, but I'm sure the listeners here as well as on the Zoom will have some questions. So I will open up the discussion for anybody who wants to ask a question or to make a comment. And I can already have 3 hands actually, but I'll give preference to people on the Zoom. And I apologize that some of you had some difficulty in listening properly in the initial part. So Ayesha, over to you.
Thank you, and thank you for sharing such a great presentation and overview of the work of the organization. It's wonderful to see the growth of this program globally, and I was wondering whether you would be able to share any exemplars from some of the country experiences about how the demand for such a package has increased from within the health systems themselves. Because one of the challenges that we often encounter on the ground, and I work in the field of early child development, is that there's often this pushback where there's a kind of a priority list and children's development or addressing delays and disabilities comes lower down that priority list. So I was just wondering if there are some good examples you could share about where advocacy has changed that narrative.
Yeah, thank you for that great question, Aisha. So you're right? I mean, I think when we started this work, and we still hear this a lot, right? That children with developmental disability is not really on the same level as other, childhood issues and challenges. I think this is where advocacy has really made a huge difference. Parents of children with autism and developmental disability are determined, if nothing else, to change the system. And they're often, in every country we have some success. And this is why I point to the Advocacy Leadership Network. It's because a parent has gotten to know the government, understand the policy levers that are in place, and what they need to do to not only facilitate change, but sustain change. And what we're able to do is to be brought in as a tool for them, right? To implement that vision for them. And I think the opportunity also to advocate at all levels, not just locally, but also to point to a global effort, global movement to enhance well-being and outcomes of our community, has also, I think, enhanced the awareness and the willingness, the political will of policymakers to do something. I'll give you a good example. I think, there's a lot of talk in the community now about how, 15 years since the World Autism Awareness Day resolution, that maybe it's time to move on from awareness into acceptance. I think that's a probably oversimplistic view. I think that different communities have different personal velocity in getting to a point where a certain social change can happen. And I think in many communities around the world, awareness is still an issue. And I think the opportunity here is that even by just making the policymaker be aware that there is a significant percentage of the population are currently going without any kind of support or without any opportunity that member of society oftentimes made a difference for these policymaker decision makers. I hope that answered your question.
Thank you, Andy. And I would just like to add that working with the top level in the government, including the first ladies and the presidents and the prime ministers, sometimes helps to generate a little bit of enthusiasm in the Ministry of Health too, going at that level. But there are more questions, so I like people on the Zoom to raise their hands if they want to, but I'll come back to you. But right now in the room, we have two questions. So Jackie, you to go.
Thank you. Thank you very much for that very comprehensive and encouraging presentation. It really is, as Aisha said, it's wonderful to see this kind of meteoric growth in such a short time. So obviously you're doing something very right. I work in kind of issues to do with child protection kind of generally, as it were. So across a range of different issues where children lack protection or need greater protection. And I'm struck listening to you and looking at the tools you showed us about how similar they are to tools that I've seen, for example, being used to help single teenage moms, with their children, or other kind of, situations where child development is a kind of an issue for a family for whatever reasons. So I wondered if you could explain, what's distinctive about this for autism, or maybe nothing is, but for example, there's an organization which you may be familiar with called Achev in Turkey. It's worked for years developing toolkits to help parents in difficult situations improve their children's development. And I think many of the features of what you showed us seem to me to be very similar, and they've also been very successful. So I just wondered, is there anything which in your mind is autism specific, or are these just general tools that we know would help children who have other cognitive disabilities or other behavioral issues and so on?
Yeah, thank you for that question. So my personal feeling is that what differentiates autism from other developmental disability is really the prominent role of behavior. It's the most common, because what you hear most of the time in a community setting is that the reason these children are excluded is because people don't understand the behavior, don't know how to manage it, don't know how to accommodate it in the existing systems, so they're being pushed out. And I think what this tool, to me, a tool like CST is powerful, right? Because in part, because it teaches caregivers and other non-specialists, meaning community members, that behavior means different things, right? Behavior becomes communication rather than an annoyance. And behavior can be leveraged to promote growth and well-being. So I think that's, to me, is where autism is differentiated from other developmental disabilities in general, both in terms of the particular challenges autistic kids and their families face in the community setting, as well as an opportunity, right, to where we can address this issue and hopefully be able to enhance inclusion of family life as well as community.
Thanks, Andy. But would you, just to take this forward, would you agree that there are many elements in the package which would be useful for children other than having disabilities?
Absolutely, yeah. I think, yes, absolutely, right? I mean, in some ways, the way I kind of see it is that CST is an ECD package for children with difficulty. limitations or developmental differences like autism. What you need to do in the CST, help address the gap, the knowledge gap, if you will. How do you promote, how can you get to similar outcome, development outcome for neurotypical children as you do in children with learning disability? I think, so some of the strategies are, of course, the same, but I think the ways it's delivered, the way it's implemented, the way it's provided to the family is different.
Thank you. Okay.
I wondered, are you familiar with a critique of Autism Speaks that's been voiced by Ari Neiman? And I wonder if you could just speak to his critique and whether you've engaged him and how you would respond.
Yeah, so I haven't spoken to Ari in a long time, so I don't know what his current thinking is, but from previous interactions, I think the criticisms are fair, right? That we as an organization did not involve autistic people as much as we should. You know, nothing without them, nothing about them without them. I think that we were founded based on the medical model of the condition. So I think those were legitimate criticism and issue for the organization. For me, having someone who has been in the community pretty much since the beginning and doing, I think, a very critical transition period for our community. When I joined the Autism Community 20 plus years ago, the proposals I was seeing was all about rare disease. The conception, model for autism at that time, due to lack of knowledge, is that it's a rare disease, right? So I can't tell you how many proposals I saw where researchers say, if I can just get 50 more families, we'll find the autism gene and we'll solve all the problems. The ironic thing is that as we learn more about the genetics, that's what drove the change in terms of our understanding. We start to recognize there is no autism gene, right? There's hundreds of risk loci. And if you want to think about it a little differently, like any other complex traits, right, is the presentation is due to a variety of factors, genetic as well as environment. So it becomes more and more like variation, part of human variation, if you start looking at even just on pure genetic level. And indeed, I think that's the perception, the concept about autism as a disability rather than disease. Now, of course, some of the variations, because of the system, because of the environment, because sometimes due to biology, lead to disability, or lead to suffering. And those are the areas where I think there are opportunities for organizations to really address the quality of life, right? Fundamental quality of life. And how do we, given the tremendous heterogeneity of needs in the community, how do we help each individual to the extent possible to live a fulfilling and fulfilling life?
You sound like Ari now. So are you representative or
I'm glad to hear you say that. I think, I think I've learned a lot, right? Through science and through interaction with people like Ari and self-advocates. Certainly, I found my own perspective about autism has evolved over the past 20 years. And I think that's reflected in the work that we do in general. We no longer invest in, for example, large clinical trial to cure autism, right? We think about a program like CST, how to facilitate inclusion, how to facilitate well-being outcome for autism.
Thank you, Andy, and appreciate the fact that we all need to learn a lot, and keeping an open mind on what is working and what is not so well working is something that we always strive for. We still have time, so if there are any questions or comments from the participants on Zoom, please feel free to raise your hands. But in the meantime, I have a question to you, Andy. In fact, I have several questions, but I'll ask one to begin with. You deliberately decided to make it a very global project, but you also illustrated that a number of sites within US are picking up and doing something. Is there any benefit that you perceive which has come from outside the US sites, which you're able to use within US? So is there a kind of horizontal transfer of skills and knowledge that you feel is beneficial for this country?
Absolutely, right? I mean, I think, we really benefit from several examples of this. So for example, when we start to implement the first Chinese language CST program in this country, we actually started with the adaptive version that was developed in China. Right? So we try to leverage that cultural understanding in order to facilitate, accelerate the speed of adaptation and communication. Same thing can be said for we literally took a high efficiency version in Ethiopia, which is redesigned for caregivers with lower literacy, and use that as a starting template for our work in the US. So we're definitely able to benefit from the work we've done globally to support the community here. And we even have, for example, trainers that have that train those international community to train in the US as well. So.
Thank you. My second question is about some of the participants who are researchers. Obviously, you are starting from what the evidence shows, but you're then implementing it. But obviously, we know some things and we also do not know other things, even in the implementation part of it. If a researcher asked you as to what are the future possibilities or future priority questions that you might like to answer from the work that you're doing, combining the research part with the implementation part, what will be 2 or 3 good questions that could be answered from the work that you're doing?
So, first question would be that we appreciate that the package as it currently stands is useful for many families, but not all families. So I would certainly like to understand what can we do to enhance this package, or is there a complementary program we can bring into the mix that will allow us to expand our coverage of the community and really better address all the unmet needs out there. That's one thing. I think the second thing is that this package right now, as it stands, is I think is reflected in some of our thinking about future directions of this package. For children that are more severely affected, this package is probably more difficult to deliver to you. And so in actually implementing this package, it really helped us to see that, right? Because we see the participants are not the ones that are more likely to be institutionalized, either formally or informally, are the ones that are able to have less support needs, to already be more engaged in the community. So another question I would like to learn is, is there a way for us to deepen or expand the content of this package so it can be more helpful for children, instead of having a module of supporting children who are minimally verbal, for example, could it be something a little more comprehensive? Because as a Lancet Commission, before they created this administrative category of what they call profound autism, which are really our children who have IQ less than 50, who have chronic medical condition, requires typically 24/7 supervision, or minimally verbal. That population remain consistently excluded from service provision, including the CST, right? I would certainly like to understand, is there something else that we can do that will allow us to better support those who are more severe, like who have more higher needs.
Andy, if you still have we still have time, but if you have the inclination, there is a question from Richard Cash, one of the most senior members of the department.
Well, thank you for that. I'm just curious, what position, if any, did your organization take with regard to the Wakefield controversy? Or did you just stay out of that?
No. We took a very strong position that we actually funded some of that research, including the research using the Danish registry to refute that hypothesis, right? That was an awful thing that happened to our community. And the negative impact of that controversy continued to resonate in our community to this day. And as you know, we are the original vaccine denier, right? So some of the things that we see in the recent pandemic, vaccine denial was a terrible flashback for us. But we're very firm and very strong, and continue to this day to say that there's absolutely no association with vaccination autism. Period.
Thank you. That's very interesting. I appreciate your comments. Thank you.
So we're coming to the last minute. I have just one last question because I don't see any other question. To what extent the kind of work that you're doing will apply also to people living with autism who are already adults?
Yeah.
Who are already adults because their needs continue.
Yeah, that's a great question, right? Because we know that because of developmental disability, and even the solution we provide now in early childhood evolves, depends on the age of the child. And if you were to put everything we know about autism on the table right now, I will argue that as you go up in the age range, we know less and less. And until we get to the older age, like 50 and 60, I will argue that we know almost nothing, right? A simple question will be, for example, what does an autistic adult with dementia look like? How do you diagnose someone like that? And the answer is we don't know. And Shih and I were talking about this a little earlier, right? So we know that autistic adults typically have a 2.5 times higher risk for premature death. Their life expectancy is 15 to 20 years shorter than your typical counterparts. The number one cause, the major cause of death for autistic adults are very similar for neurotypical adults: addiction, cardiopulmonary disease, suicide, cancer, and so on and so forth. But just think about this. We have prevention programs for every one of those NCDs. Everyone. And we have none of them for this population. So essentially what we're saying is that for 2 to 3% of their society, they're off on their own in the older ages with NCD. So everything that we have learned today, everything that we're implementing in the community right now, does absolutely nothing for them.
Andy, with that challenging note, we come to the end of the seminar, but thank you so much for joining us and giving us such a wealth of knowledge and experience. And I'd like to thank all the people. The contest for how many people join has been won by the people on the virtual platform today. Thank you for joining, and let's give a hand to Andy.
Thank you.
Thank you.